Thank you, Mr. Chairman. I want to thank all of our witnesses for being here today. I ask consent that I can put into the record, Mr. Chairman, letters that I've received from people in Maryland in opposition to this bill and groups without objection so ordered. I want to point out that the process being used here today, I want to just make it clear. We are 8 months past the time Congress, Senate passed the budget that we are now reconciling to with this amendment. We are finished the debate time on the floor of the United States Senate. We have had no committee markups, no chance for amendments. We don't have a CBO score on Senator Cassidy's proposal. We do know, though, that tens of millions of people will lose their coverage, premiums will go up, and the quality of coverage will go down. We do know that. So, Mrs. Miller, I want to concentrate on comments that have been made here. Senator Cassidy, I think, correctly identified the problem. We have a problem in the individual marketplace with individuals who are not receiving subsidies. And that's all the examples that Senator Portman just gave fall into that category. Now, in my state, I believe that's about 1% of the population. Now, that's a significant number. I'm not trying to underestimate the problem, but could you just confirm whether the numbers I'm talking about are correct?
Yes, Senator. In Pennsylvania, we estimate that that population is between 1 to 2% of the population. So, as you said, very small, very important because they're buying coverage on their own, but very small.
So the proposal that is being brought forward, though, will affect tens of millions of people because tens of millions of people are going to lose their coverage. Many others are going to lose the quality of their coverage. And we're going to see significant cost shifting for those who don't have health coverage. Mr. Smith, I think, correctly analyzed what the states are going to have to do. And I'm going to use his language. He says they'll manage to the cap. And I think that's accurate. States have budgets. They have to comply with their budgets. States have already shown great initiative in delivery system models to try to bring down costs and make the system as cost-effective as possible. So what is left to manage to the cap seems to me are two major factors. Reducing eligibility, cutting people off the Medicaid rolls, and then since they no longer have the mandate on essential health benefits, it's going to eliminate certain benefits that are currently covered. Is there other options available that I don't see?
Is that to me?
No, this is Mrs. Miller.
Oh, okay.
When you're trying to cut the dollars out of a program like we would be doing, you really only have three levers. You can reduce the number of people receiving services, you can reduce the services that you're providing, or you can reduce payments to providers. And that's really those are really your options.
So that's how you manage to the cap. So I just go to one of the individuals in Maryland who I was with today, Peggy Roche, was talking about her daughter who has absence epilepsy. And she's very concerned. You gave some genetic examples of families that have children that are born with disabilities and how they're going to be at risk because the state, in managing to the cap, may have to limit the amount of services they provide to these high-cost individuals. So we had today a New Jerseyan, Allison Chandre, who identifies philosophically with pro-life, whose child was born with a rare birth defect, heterotexy. There wasn't a dry eye in the room as she explained what she's going through. But she said she knew at least this nation would take care of her child, that she wouldn't have to go into bankruptcy, that she had a protection that was out there. Aren't we in danger of losing that protection that's out there that we say every child, every person is entitled to make sure that the benefits available? Isn't that lost under this proposal?
I believe it is.
And I could go through those that are suffering from the opioid drug addictions. We know before the Affordable Care Act that the programs didn't cover those services. That's certainly at risk as the state manages to the cap. Would you agree with that?
That's true, and I think it was brought up that mental health parity stays in place, but mental health parity doesn't guarantee access to coverage. It requires parity if you have the coverage to begin with, but that would not be guaranteed going forward.
And as Senator Carper pointed out, this proposal doesn't even deal with that 1% problem, because there's nothing in this bill that shores up the individual marketplace to deal with the specific problems that those that are trying to repeal the Affordable Care Act continue to monitor. These are real issues that we have to deal with. And yes, dealing with the cost sharing, dealing with reinsurance, dealing with the mandates, that will actually deal with the problem, not this bill. And what we put at risk, we all talk about our compassion for those who suffer from cancer. But we know that some of the treatments are pretty expensive. Managing to the cap is going to limit the opportunities of those, for young women who have breast cancer, the type of treatments that will be available to them. I think that's what, Mr. Woodruff, you're saying is at risk. Thank you, Mr. Chairman.
Absolutely.